congenital and acquired pediatric orbital lesions. Briefly, I will discuss microphthalmia, macrophthalmia, coloboma, dermoid and epidermoid cysts, nasolacrimal duct cysts, vascular lesions, teratoma, and phacomatosis. Regarding the acquired lesions, Langerhans cell histiocytosis, orbital pseudotumor, orbital cellulitis, rhabdomyosarcoma, leukemia, and neuroblastoma. Regarding microphthalmia, it's a small ocular globe with an ocular total axial length, 2 standard deviation less than that of the population age adjusted mean. It may be just simple microphthalmos with intact globe and decreased total axial length, or it may be complex microphthalmos referring to a globe with anterior segment dysgenesis or posterior segment dysgenesis, in addition to mild, moderate, or severe decrease in total axial length of the eye globe. Here an example of right microphthalmos. The right eye globe is evidently smaller than the left one with small globe. On the other hand, macrophthalmos is defined as diffuse enlargement of the anteroposterior diameter of the globe. It's called bophthalmos, including the anterior and posterior chambers, usually due to primary congenital or infantile glaucoma or due to syndromic glaucoma as seen in neurofibromatosis type 1 and Sturge-Weber syndrome. It's very important to image these patients because not all large globe are due to macrophthalmos. It may be due to intraocular mass, so imaging is required for differentiation. This is an example of macrophthalmic or bophthalmic eye globe on the right side when compared to the left one. And this patient has NF1. We can see here the plexiform neurofibroma along the lateral aspect of the globe, in addition to dysplasia of the sphenoid bone and nerve sheath tumor at cavernous sinus and Meckel's cave. Coloboma is a developmental anomaly resulting from incomplete closure of the embryonic choroidal fissure, leading to ectasia and herniation of the vitreous into the retroocular space. It can affect any site in the globe. However, the most common site is the posterior nasal inner side. It can be unilateral or bilateral and can be isolated or syndromic like in Charge syndrome. On MRI, coloboma appears as a focal defect of the posterior wall of the globe, sometimes associated with microphthalmia. This is an example of a young child with a left proptosis. On MRI, we found a retrobulbar colobomatous cyst with small eye globe compared to the right one. Dermoid and epidermoid cysts are the most common congenital orbital masses. They arise from sequestrated epithelial rest as suture lines, or they may occur within the orbit. They are called deep or intraorbital dermoids. They are composed of cysts lined by keratinized stratified squamous epithelium. Dermoid contain adnexal structures such as hair and sebaceous glands. On contrast, in hand CT, these lesions present as well-defined low-density masses. They remodel the adjacent bone, which is a characteristic feature. If there is a rupture of the dermoid, there will be thick, irregular rim enhancement with perilesional inflammatory changes. This is an example of superficial dermoid occurring along the frontozygomatic suture. On T2, it appears bright signal. On fat suppression T1, the signal of the lesion is dropped. And on CT, you can see the remodeling of the adjacent bone without frank bone destruction, and the density of the lesion is fluid density. It can be intraorbital dermoid, like in this case, it has extraconal location, and this dermoid ruptured, leading to severe inflammatory reaction with surrounding the intraorbital dermoid with thick enhancing wall. Nasolacrimal duct cyst or dacrocystocele and mucocele formation typically is congenital in nature due to failure of canalization of the distal nasolacrimal duct at the valve of Hasner. This common anomaly is detected incidentally or because of a cystic medial cancer swelling, or it may present with neonatal nasal obstruction. On imaging, it appears as a cystic expansion of the medial aspect of the eye globe, and the nasolacrimal duct characteristically extends inferior to the inferior turbinate, where it opens in the inferior meatus. And this point differentiates the nasolacrimal duct cyst from cephalocele or neuroglial heritopia that would reside superior to the inferior meatus. Vascular lesions include infantile hemangioma, venous malformation, and venolymphatic malformation. Infantile hemangioma or capillary hemangioma is the most common vascular tumor of infancy. It has a proliferating phase during the first year of life. Then involution occurs by the age of 7 to 8 years. On CT, it appears as a isodense mass with intense enhancement, and on MRI, it is isodense to the white, isointense to the white matter on T2, and has signal void structures within its matrix during the proliferating phase. While in the involution phase, it is associated with decreased vascularity and enhancement and increase in the fibrofatty matrix. This is an example of right orbital and periorbital infantile hemangioma appearing isointense to the white matter on T2 with multiple serpiginous signal void structures within its parenchyma. On T1, it is isointense to the cortex, and post-contrast fast suppression shows intense enhancement of the infantile hemangioma. Usually it is diagnosed during first year of life. Then it involutes gradually. Venous malformation is a distensible low-flow lesion characterized by dilated venous channels. It's a well-defined cystic septated lesion with gradual enhancement post-contrast sequence. Phlebodesis are a characteristic feature of venous malformation. This is the right eye globe shows conjunctival injection with mild proptosis. MRI showed large intra and extraconal mass, bright on T2, showing gradual enhancement, and these lesions are characterized by intermittent proptosis. They increase in size with valsalva or with leaning forward, leading to proptosis of the eye globe. Lymphatic malformation is non-capsulated mass of thin-walled lymphatic channels representing the most common vascular malformation in children. They appear as microcystic or macrocystic with lobulated borders and septations. They are usually large, transspatial, involving intra and extraconal spaces, and a characteristic feature of venolymphatic malformation is the presence of multiple fluid levels when hemorrhage occur. There's an example of orbital lymphatic malformation with ecchymosis and proptosis, edema of the eyelids. On CT, there is intraconal mass with multiple fluid levels, hyperdense. On MRI, the characteristic feature of venolymphatic malformation is the presence of multiple fluid levels due to internal hemorrhage leading to sudden proptosis. Teratomas, they are derived from more than one primitive germ cell layer and are usually benign. The tumor may be cystic or solid and present at birth or in infancy with proptosis. On CT and MRI, it appears as unilocular or multilocular cystic or solid, and the characteristic feature of teratoma, like elsewhere in the body, is the presence of tooth, calcification, fat, and soft tissue components. So a mixture of these components. It may be intraconal, like in this case, where there is a soft tissue mass in the intraconal space, demonstrating well-formed tooth and bone, in addition to fat and soft tissue component, which are characteristic of teratoma. Phacomatoses or neurocutaneous syndromes is a large heterogeneous group of multisystemic disorders. The most important is NF1 and Sturge-Weber syndrome, tuberous sclerosis. This is an example of NF1 presenting with bilateral optic nerve gliomas and extending to the optic pathway. Also, characteristic features in the orbit are the plexiform neurofibroma, orbital and periorbital, and extending to intracranial space with dysplasia of the sphenoid bone and enlargement of the middle cranial fossa. Also, the plexiform neurofibroma can extend to the periorbital soft tissues. In NF2, which is characterized by bilateral acoustic neuroma, optic nerve sheath meningioma may occur. And this is a case of left-sided perioptic meningioma with left-sided proptosis. You can see here the lesion is surrounding the optic nerve, showing characteristic tram track enhancement. And on CT, we may find linear calcifications along the lesion, giving also the tram track appearance. Langerhans cell histiocytosis or eosinophilic granuloma is the most localized and benign form of Langerhans cell histiocytosis. Presents as unifocal bone disease or multifocal, usually in young children. They appear on CT as osteolytic lesion with sharp edges or punched out edges or beveled edges. And on MRI is the modality of choice to demonstrate intracranial extension. There is an example of left-sided eye swelling with ptosis. And on CT, you can see here osteolytic lesion involving the lateral wall of the orbit and the frontal bone with sharp beveled edges. MRI is better in detection of intracranial extension. You can see here osteolytic lesion at the lateral wall of the orbit with intraorbital and intracranial soft tissue components. Orbital pseudotumor, although it's more common in adults, however, pediatric cases account for about 11% of the total number. Typical imaging include extraocular muscle enlargement with involvement of the myotendinous insertion and infiltration of the orbital fat. The differential diagnosis is, of course, infection, Graves' disease, and lymphoma. There's an example of left-sided orbital pseudotumor with myocytic involvement of the extraocular muscle and extending to the myotendinous junction with marked stranding of the retrobulbar fat here. This is an example of idiopathic orbital inflammatory disease. Orbital cellulitis usually occurs secondary to adjacent sinusitis. It may be preseptal or postseptal. The preseptal type is usually due to skin pathogens, while the postseptal cellulitis usually due to adjacent paranasal sinusitis. This is an example of preseptal cellulitis involving the preseptal compartment with marked thickening and edema. This is an example of ethmoid sinusitis complicated by subperiosteal abscess along the medial wall of the orbit with orbital cellulitis. Ultrasound can detect also the preseptal collection in cases of preseptal cellulitis with hyperemia. And this is an example of ethmoid sinusitis complicated by subperiosteal abscess with lentiform collection showing marked enhancement of the margin with displacement of the medial rectus, and this subperiosteal abscess is an emergency condition. Also, it can be complicated by thrombophlebitis of the superior ophthalmic vein. This is normal superior ophthalmic vein, and this is thrombosed superior ophthalmic vein with hypodense center and marginal enhancement. Also, cavernous sinus thrombosis can occur secondary to orbital cellulitis. Now we come to the tumors that may involve the pediatric orbit, and the most common is rhabdomyosarcoma. It is the most common mesenchymal tumor, and usually it is unilateral. On CT, it appears as extraconal or intraconal, or intra and extraconal with aggressive bone destruction. This is an example of large orbital mass with destruction of the left maxillary antrum. It is iso-intense to the extraocular muscles on T2, showing enhancement. This is another example of intraconal rhabdomyosarcoma showing restricted diffusion. Another example of rhabdomyosarcoma showing intense post-contrast enhancement with right proptosis. Leukemia can involve also the pediatric orbit, especially the granulocytic sarcoma. It is the most common form of acute myelogenous leukemic involvement. These solid tumors typically present in children with proptosis and diplopia. They are usually bilateral, opposite to the rhabdomyosarcoma, which is unilateral. There is an example of CT showing bilateral leukemic infiltration or chloromas involving the intraconal and extending through the superior of the orbital fissure to the middle cranial fossa. Also here, the lateral aspect of the globe, and extending to the infratemporal fossa. Also, it can be very subtle, like in this case, MRI fat suppression T1 post-contrast shows perineural or optic nerve involvement, as well as involvement of the medial rectus. Also, the fundus shows retinal vein thrombosis. Lastly, the neuroblastoma, which is an abdominal malignancy occurring in young children, can metastasize, and the most common primary childhood cancer to metastasize to the orbit is neuroblastoma. It can be unilateral or bilateral, and can give eyelid ecchymosis or raccoon eyes in children. And on CT, the CT is helpful to show the characteristic periosteal reaction and the permeative or lytic destruction of the bone, while MRI is superior in detection of the intracranial extension of the lesion. This is an example of metastatic neuroblastoma, bilateral temporal bossing with large masses involving the lateral wall and middle cranial fossa with intraorbital and intracranial as well as extracranial soft tissue masses in this child with left suprarenal neuroblastoma with metastatic lymph nodes. It can be unilateral, like in this case, or it can be bilateral. And the bone window is very characteristic to show the speculated periosteal reaction. So at this site, as we have seen, it can be involved by Langerhans cell histiocytosis, leukemia, lymphoma, metastatic neuroblastoma. Thank you very much.